today. I'm going to just do a talk about my project mainly, about me, and about what KES has opened up for me in terms of experience. I'll go through the title first, Developing a Researcher Within a Healthcare Profession, The Path to a Successful Future, which hopefully by the end of the presentation you'll understand a little bit more why I chose that as a title. I'm going to give you a little bit on my background. You see, Danny Clegg, that's me. I'm not related to Nick Clegg, anything like that. So, and yes, I'm a KES PhD student, as Penny said. I'm in my final year. I work from a research unit within the University of South Wales called the Clinical Technology and Diagnostics Research Unit, which is the first time I've spelt that correctly in a year. So I'm going to be basically just introducing where I started, where I've been, and how I've got here today, and things I've learned along the way. And a lot of things have changed. I've gained a lot of experiences. But I've just put two pictures on here to start off by showing you how I haven't changed. So this was a picture of me at the my undergraduate Christmas party in 2007. And this is a picture of me from my undergraduate Christmas party from 3 weeks ago. So there are certain things where I have changed, other things where I haven't. And they're also two of my favourite photographs. And hence why my hair is so short at the moment, because I had to mohawk it again. Anyway, so yeah, I'm going to just talk a little bit about me and my background first, and the project, and what I've learned throughout. A lot of new skills and a lot of experiences. I'll try and get through them all today. And rather than just talking about what I've seen and done, how it's all benefiting me, how it's benefited me so far, and how it's going to benefit me in the future. And finish up by talking about what the future holds in terms of what I would like to do, what I have the opportunity to do, and so on and so forth. I do apologise. I hate talking about myself. I really do. I think we all do when we're doing presentations like this. If I say me too many times, just put your hand up. Yeah. And again, if you want to ask any questions at any time, feel free to. You don't. But at the end, I will leave some time to ask any questions you may have. Okay. So I've arrived here today basically because I was looking at my project and thinking there's not much more I can do in terms of the actual study itself. I've collected most of my data, and the KES projects operate with a budget for travel to conferences, travel to seminars, and I realised that in the 2 years I hadn't spent any of it, apart from one conference I went to present a poster. And for reasons which I'll explain later on, I realised was opportunities to see what other educational institutes are like. So I wanted to go around and shadow. That's how it started. And so far, this is my second institute in 2 weeks. And it didn't finish at shadowing. It naturally evolved to, can you please give a talk, presentation, and I gave a couple of lectures last week as well. And I think the main thing I'm looking for is to get some feedback from other students who are on KES projects at different institutes, because the University of South Wales has they have their way of operating, and I've seen very quickly that other universities have a very different way of operating. So it's nice to get feedback and to be in a different environment. Also, looking further towards the future, possible postdoctorate or research assistantships. It's nice to know what the capabilities and what equipment universities have. It's also good to always discuss my research with new people. I found in my first year, I would try and give a presentation about what my research is, and unless people were in the healthcare field, it wasn't coming across very well. I wasn't very confident. I didn't really know how to present a healthcare topic to people who weren't particularly healthcare minded. So I was far too technical. So I've now managed to get it to the point where I think I can explain it to anybody, no matter what the field is, and people seem to come away understanding it a little bit more. So it's always good to discuss it with new people. And also, yeah, to soak in the North Wales sunshine, as we can see. Good job I brought my factor 40. Right. So I'm going to start right at the beginning. I was born in Wigan, in England, and I lived there for 22 years. And I left secondary school with 12 GCSEs and then went to college, but my heart wasn't in it. I wanted to go out and work, and I put a half half attempt into a lot of things that I was doing. I don't think I was mature enough at that point. So I left at 18 years of age. And I think I'll show you my work history, because these are some of the jobs I have. This is not all of them. When I was 18, I was offered a job as a nightclub manager, which, as an 18-year-old lad living in a town where the main money area is nightclubs and pubs, fantastic opportunity, great. But I was also working as a part-time chef and a barman somewhere else as well. So some of the jobs I've had were, my favourite one ever was still, I was a pet shop livestock manager at 14, which basically meant I was a guinea pig salesman. We sold rabbits as well, not just guinea pigs. But I've done all fiberglass winding. I don't know how I Forrest Gumped my way into that job, but I ended up working in a factory winding fiberglass straight from a furnace, and inevitably ended up in hospital as a result. I'm very, very accident prone, as you're going to find out in a little bit. But yeah, I didn't know what I wanted to do all the way through. This is me training guinea pigs. And this is a theme park I used to work at. When I watched American Beauty once, and Kevin Spacey said he used to work in, his character, I used to work in a burger joint, just flipping burgers all day. It's probably the best time of my life. And working in that theme park is still one of the best times of my life. I had so much fun, minimal responsibility, and I think if we could all go back in time, we'd do it again. I would definitely do it again. But yeah, even though I was quite going off the rails a little bit when I was in my late teens, I still always wanted to study chiropractic when I matured. I convinced my brother to leave his medical path and go and do a chiropractic degree, and I could see how happy he was that I had convinced him to do this. And he became an inspiration, so I started to want to come and do the course as well. But then my children were born. My daughter when I was 19, my son at 22, so I can't just go to university until they're a little bit older, concentrate on working. And we moved to Anglesey in 2002, where I started working as a healthcare assistant, working in nursing homes on Anglesey. One, I don't know if you know anything, at Bryn Mell Manor. I worked there for quite a while, and Spring Home in Pentraeth. And at Spring Home I quickly became not supervisor, like a head healthcare assistant, and I realised that I was enjoying working in healthcare. And so I was looking at nursing, I was looking at chiropractic, and I decided to go back to what I always wanted to do initially, and I applied to the Welsh Institute of Chiropractic down in South Wales, which used to be the University of Glamorgan, and started the course there. This picture of me with my kids, for my one decent picture where I'm not in fancy dress. And this is the Welsh Institute of Chiropractic, which became my home and has been ever since 2006. I did a foundation year. My education, like I say, I didn't really do that well at college, and I thought if I start a degree programme which is notoriously difficult and has a high dropout rate, I was going to crash and burn in my first year. So I did a foundation year first, which really helped me get used to being in the university. So my skills started to develop in this area here, and particularly patient handling, manual therapy techniques. We're fortunate enough to have an established chiropractor with us today, so he'll appreciate all of these things that you learn at undergraduate level. By the end of it all, I came out with a chiropractic degree 2011. And most people would just go straight into practice. You would go and work for an associate, or you might go and work on your own. You might open your own clinic, because you don't have to spend time working in a hospital or anything like that. When you graduate, you can go straight into practice and treat patients. So that was what everybody else I knew was doing. And that's what I was all the way through the first 2 years planning on doing, and even towards the end I was planning on doing as well. While we were there, we got some really non-curricular extras. We were able to shadow orthopaedic surgeons at the Prince Charles Hospital in Merthyr Tydfil, and we also got to examine cadavers as part of our undergraduate course. So we were, even though we're a separate profession, we were encouraged to watch what the medical students were doing at Bristol, and also to be fortunate enough to be allowed into the operating room, scrubbed up, standing a yard away from the orthopaedic surgeons. Fantastic experience. But by my second year, I got to the point where I was talking to one of my lecturers and I realised the profession, it's quite a young profession, they kept saying it's quite a young profession, but it should be more established. And a lot of what a lot of the problems were not enough research being done in certain areas. And the medical association quite often would, I've not mentioned the name of the main aggressor, but had a problem with chiropractic. And it didn't really have something he'd written in a book. So there was all these problems going on. And the first thing I was told by my lecturer is, nobody's doing research. And if they are, it's just recycled reviews and there's nothing new being done. So I decided that I wanted to eventually, when I got into practice, do some of my own research as well. So even as early as the second year, I wanted to do that. We all got to do research as an undergraduate, which was a module rather than an actual full research project. So you're limited by time. It's not prioritised by the students at all, and it's not really forced on us by the lecturers at all. So it was it's changed now since I've been teaching and trying to force it onto the students postgraduate. It's changed. People are approaching their research projects with different ideas and thinking about publication opportunities even at undergraduate level now. So it has changed a bit. The big problem was there's no funding for it. Whatever you've got in your department you can use, or you can put money in yourself. There was no funding available, so the projects were limited and very frustrating. But by my final year, I was treating patients in my clinical year, decided I'm going to go into a practice and I'm going to do research when or if I get time, 5-10 years down the line. I was quite happy to do that. My undergraduate research experience was a condition called hypertension-associated hypoalgesia, something which I wasn't given as a title. I was told to just have a look at blood pressure and medications, and I discovered this, that people who are hypertensive have a lower perception of pain. So pain scales, if you do a scale from 0 to 10, people who have hypertension tend to report lower scores for the same conditions as people who are non-hypertensive. And then when the people are medicated, their pain scores go up. So it was suggesting that people who are hypertensive have hypoalgesia. And it was quite a weird phenomenon. Nothing conclusive, and it had been very well discussed, but it hadn't been assessed within a pain clinic environment. So I spent a few weeks sat in a bunker, data mining, finding people who fit into either category, and it was still consistently, significantly different between people who were hypertensive and not. And then, yes, I was offered a job working with my brother. He was a chiropractor back in England and had a nice associate position ready. And in typical accident-prone fashion, I was watching the royal wedding day, which turned into a royal wedding party day, which turned into me tripping as I was walking home and breaking my wrist, which meant I couldn't treat patients for 3 months, which meant I wasn't going to leave university on time. I was told I couldn't do my exams in time, which meant I had to give up the job that I had. Then, as I was in the couple of weeks deciding what I wanted to do, a KES MRes project was offered by the university. And I was more interested. I thought, I've not had an interview anywhere. My brother offered me a job without an interview, and I thought it's going to be a really good experience to go and have an interview for a position. And I was just curious. The lead on the project was one of my lecturers. He lectures in neurology and pharmacology on the chiropractic degree, so I went to see him for a chat, and he said, I might as well come along for the interview. And then the more I read about KES and about the setup with the funding and the budget for travel, for equipment, and so on and so forth, by the time I came to the interview, I wasn't just curious, I wanted it. I really wanted the position. So I'd done a lot of research into the project before I got there, and very fortunate I did get it. There's a picture of, we had our photographs done around about the time I'd broken my arm, so you can just see a little green cast hiding under. I had a different coloured one every week, so proof that I did break my wrist. So yeah, it took a lot of time to adjust. I think I spent more time trying to focus and adjust in the first 3 months than I did doing anything on the actual project. It was a completely different world. I'd never worked with a company before. And the KES projects are a collaboration between university, a company, and money provided by the European Social Fund. So to suddenly be going from sat in a classroom falling asleep to treating patients, and then to being in a room with people while there's tens of thousands of pounds being spoken about and budgets being spoken about, I was a little bit out of my depth. Luckily, I had a very good supervisor who helped me settle. All the academic staff who had taught me and shouted at me for the previous 4 years, 5 years even, he'd been frustrated by undergraduates, as they all do. Suddenly, I'm upstairs in an office with them. So that took a lot of getting used to as well. The project in its first year went really well. It went a lot better than we'd ever anticipated. And it evolved to a point where we decided we could do with more funding, and also a secondary project developed as a result of the first one. So it was a very nice surprise for us that we suddenly had another opportunity to get another researcher in to continue a project in another direction. But we applied for more funding, and I was able to have another 2 years funding because there was enough work based on what I'd done to continue for 2 years more. So rather than submitting the MRes thesis which I had written, I turned that into a transfer of progress, was transferred to PhD, and took it as year 1. Year 2, and now I'm in my final year now, year 3. One of my favourite skills that I picked up along the way is I've learnt to use a sewing machine, which will make a bit more sense when I show you some of the things that I've been doing. Yeah, it's on schedule. Should be completed this year, next year, sorry. As well as the experience in research, I was pushed to attend as many courses as possible, and one of the ones that I've just finished and should be being awarded this week, it's been through our exam board, is a PG Cert in research. And I've been presenting at open days, so it's given me experience in presenting to people I don't know, like yourselves today, but also in the university to other faculties. I've been to one major conference, the World Physiological Society. I presented a poster there. And again, it's built my confidence. A couple of years ago, I'd have been stood here like this behind the screen, and I feel a lot more confident talking to people now. And the big thing is, the project I've got, it's not related to chiropractic. My aim was to be a chiropractic researcher. So what a project has done, rather than giving me a chiropractic project, is it's taught me how to it's given me the skills and the experience to go ahead and think about how to design a project from the start, how to apply for funding, and how to eventually one day be lead on a project as well. And I'm starting to think about what comes next. There's not a lot of time left yet. This is from the KES national event earlier this year. What one of you called it? The James Bond pose, was it? Not quite. Right. We're now going to talk a little bit about the project. My project centres around Raynaud's disease. This is a condition. It affects about 10% of people in the UK, and when you look at studies worldwide, demographic studies, it seems to be consistently about 10% in most countries, particularly northern countries with a colder climate. The simplest way to explain it is every part of your hand, your foot, your fingers, your toes, receive blood supply. And good proliferation means the whole of your hand should feel a uniform temperature. We can all get cold hands, especially in cold weather. If we put our hands in water, we can all sometimes feel a little bit cold, but usually a little bit of movement, a minute later, your hands return to normal. People with Raynaud's disease have insufficiency in blood perfusion to these areas, in particular the hands and the feet. And while it might be a case of, and a lot of people think, oh, if your hands are cold, just put them in your pocket, just warm them up. For these people, it doesn't always work like that. There can be some very, very severe cases where the hand will not warm up, and when it does, it causes burning, paining, and a horrible sensation for quite a period of time. It could be quite debilitating for some people. If it's a secondary Raynaud's disease, so the person has a underlying connective tissue disease, such as lupus or systemic scleroderma, then these people can quite often have no blood supply to that area. The hands will ulcerate, the tissue will die, and the fingers are cut off. And it's quite a lot of people I've met with this condition have extreme deformities, can't use the hands, and have fingers missing. So it can be a very, very severe condition. And the actual Raynaud's component of these conditions is quite often the first set of symptoms to manifest in young people. I recently worked with a rheumatologist over in the Czech Republic for a day, and a fascinating experience working with him, because he explained to me that he's a paediatric rheumatologist who specialises in Raynaud. It was a complete fluke to land in his office. I didn't expect to ever meet somebody like that. And he said that he sees children who have Raynaud's disease, and he started looking for doing new tests to find out if these people may develop a connective tissue disease later in life. And if so, from a pharmacological perspective and anything like that, if there's something you can target from a younger age that's going to prevent these diseases from happening, it's great. So there is other research going on apart from this. Typical pictures that you will see of people who have this condition are these three pictures here. The one on the bottom left, this is someone who has scleroderma, who has the connective tissue disease, and you can see the deformities occurring from the knuckles onwards. The one on the far right, that's where the hands just go white. This is quite often a primary condition where your blood supply may be affected because of the actual vascular cells inside the arteries and the capillaries, but more often than not, they say it's caused by the overactive sympathetic nervous activity. Yeah.
That's quite an impressive picture. Is that typical, or is that an extreme case?
That is typical of primary Raynaud's, yeah. And most people who I've had in the studies have either reproduced this or have said, oh, my hands haven't gone white this time. Sometimes they go white, which, again, I've got these images off the internet. I've not put anybody's hands on here who I've seen. And when I was over with the rheumatologist last week, he was able to show me images of the children who were anything from age 5 to 15, and they were even more severe than these. Yet they were still considered primary. In order to be considered secondary, you have to go from white to blue to red. That's for where they say is secondary. The one in the middle here is a secondary Raynaud, very severe, and it wouldn't be too long before those fingertips have to be cut off. So that's just to show you three different types, how it can appear. So yeah, the project itself, funded by KES in partnership with my company sponsor there, Tona Silast. They specialise in medical garments, based in Latvia, but they have a European branch based in Tredegar in South Wales. Tredegar, have you pronounced it? Did I pronounce it wrong? All right, Tredegar, sorry. Oh, no, I spelt it wrong, that's what it is. Okay. So the European branch is aimed, it's a very small part of the company. They typically work with Eastern European, Russian, Latvia, Estonia, but we're trying to get a lot of our products into the UK. And they were curious in how could they use the technologies that they already have, the materials that they already use to create gloves which are better going to treat this condition. There are a number of medications you can give to people to treat it. If you're overactive and your vessels aren't dilating, you can give calcium channel blockers. You can, basically, hypertension medications are given to people who have this condition. Very, very common. But people don't like taking medications which are designed for something else, even though they're having a benefit. There is no Raynaud's disease medication because most people will live with it, get on with it, or have a condition which is treated by a different medication. So therefore, for the pharmaceutical company, there's not much money in it. So the best way to treat it, people find, is to stay warm, to keep warm, keep you get the symptoms in most cases. So looking at the gloves which they use and trying to make them better, that was the basis for their product. The Raynaud and Scleroderma Association told us that the provisions currently available for people with Raynaud's are poorly designed. They are a great idea. Some people will find them effective, some people won't, but the most common problem is if you've already got a problem with your hands and you've got giant, thick, warming gloves on with heating elements and things inside and you need to get some change out of your pocket, you can't. The glove has to come off. The change in temperature, the hands shut down. And you can try and put the glove back on and warm it back up again, but it can take hours. So there was room for us to try and work on improving this. So that's why I showed a picture of a sewing machine. I went from a chiropractic career to stitching materials together to try and make gloves, which did not work very well. So that was a one-year MRes project. These are just some of the materials I tested. I was fortunate enough to be working with another PhD student who created some calibrated temperature sensors. So I was able to place these inside reusable heat pads, activate them and see how long it took for the heat see the temperature change over a period of time. Then by wrapping them inside the different materials and the different gloves, I was able to do comparisons to how the heat dissipated over a period of time. So yeah, I did 72 different tests. Each one took 150 minutes, and that was the MRES. But it was 12 different materials, some of which were combined together. Just to give you an idea, these are some of these specialist Raynaud gloves you can buy. As you can see, they're usually ski or motorbike gloves, so it can be quite costly. But I'm going to get this picture a little bit bigger for a second here, I think, if I can. I can't. I X-rayed inside the gloves to see what they look like rather than tearing them to shreds, which I eventually did anyway. I had a look inside on X-ray to see where the heating elements went, and each design was very different. Some heated the whole of the fingers, some the whole of the hand and the fingers, and one heated just a band over here. So it looked like there was some reasoning behind why people would choose to do this. We started looking at what happens if you were to heat the hand proximally or distally. If you were to heat the hand proximal, so the blood entering the fingers is warmer, is it going to have an effect? Is it going to be suitable for us to place heating elements strategically to actually reduce battery sizes, reduce the thickness of wires and things like that, and overcoming another problem which people found when they wore them, restricting battery packs. These giant lithium-ion battery packs across the back of the wrist, so you can't extend the wrist properly. And I tried wearing them for an hour and doing normal household tasks, impossible. So there was a lot of room to actually take the project forward on more of an electronic and technical level in terms of creating elements with smaller batteries. Yeah, so that's what I've just said there. I started thinking about this, and then this second project was born based on the thoughts and the findings from the initial part of the study. So second project, working with different companies, was born, but still led by Tona Silast. So we've got the lead on 2 projects now. I did get to go to the head office in Latvia and see how medical garments are made, which again was a fantastic experience, because I was able to then have an appreciation that even though I don't think it's hard to stitch together 2 pieces of material, I know what people would have to do by hand and what they could do by machine. So that was very helpful. And I said to them while I was there, I've got these 3 materials, I'd really like them to be together. And someone took them and disappeared and came back 3 hours later with 4 different size prototypes for me. So again, kind of thing you have to wait 2 or 3 months for normally, as I've found out since. But I was able to get things made straight away there. And it was right in the middle of winter, beautiful place. And I found a cat in a restaurant. I think that's what it was. I can't remember what that picture was. Then yes, we got the funding and year 2 started. So I was able to put even more materials together and get thinner materials from around the world to put them together, and suddenly started finding that particular materials were outperforming thicker materials. So I was able to get really, really thin materials, which are a little bit more expensive, but that have high infrared reflective properties. And we got to the point in year 2 then where we knew which materials we wanted. Aside from that, the typical way to assess Raynaud disease is put the hands in cold water. The methodology they use in the Czech Republic is hands in water between 0 and 10 degrees for 10 minutes, and then measure the hand. Now, if you imagine that your hands go to a point where they're numb, burning, hurting and painful, and you're being whacked into cold water, it's not really a very ethically sound methodology. So I was curious, if you're trying to cause symptoms to manifest, what could you do what kind of things would happen to the hand if you tried to alleviate symptoms instead? So I started creating new testing methodologies. And based on the principle I'd learned that when you take your hands out of gloves which are warm into an environment which is a few degrees cooler, your hand can shut down. I started to think that maybe it's not cold itself that causes the vessels to shut down, maybe it's a change in temperature. So I've moved the parameters a lot closer to the room temperature, a long period of climatizing at 22, 23 degrees, And rather than using water at 0 to 10 degrees, I use water at 18, 19 degrees instead. So by having a very, very small shift in temperature, could I still get people to shut down in the same way? And then also I had people who were being warmed, so heated to 5, 6 degrees above the ambient, just to see what happens as well, with the idea being that areas which have got severely damaged vasculature will not react in the same way as areas which do not rather. So yeah, going back to the prototype on the bottom left there, middle one is a prototype I had made in Latvia. The right one is a prototype I had made by a professional glover in Liverpool, which is a career I never realised existed until I started this project. And the left was my attempt on a sewing machine. So we quickly decided that no matter how enthusiastic I was, it was never going to happen. The pictures on the bottom right is the typical setup. Picture A is the infrared camera directed from above, so it takes images of the hands. Picture B there, I've used one set of hands taken, a typical image taken of this particular subject here. He was happy for me to use his hands for demonstration purposes because he had neurofibromatosis, quite a severe condition, but he was a really nice guy, and he thinks his Raynaud's was related to that, although there hasn't been a lot of literature to back that up. So yes, as I've explained, this new testing methodology, I wanted to try and find, so the old method, hands in cold water, I changed it slightly, brought the parameter up, and then for warmth, trying to use warm water, we piloted it, and to try and find a container which will keep water warm at the temperature we wanted was quite difficult. And so I decided, right, well, let's create an environment. Rather than the hands touching the water, we place the hands inside a bag instead, so that they're not in contact with the water. When you take the hands out, the hands are still dry, but it's actually surrounded by cold. I then tried to think of a way to warm the hand in a similar way. So how can we get the hand warm without them actually being in warm water? And I wanted to try and aim for equipment 28, 29 degrees, and I ordered a baby chick incubator and put cardboard around it, and every time I turn it on, it hits 28 to 29 degrees. It's complete, again, it wasn't, if you see a picture of it, it's not the most scientific looking thing you'll ever see, but it's working. The pilot went really well. The pilot's been presented at the World Physiological Society, and it generated a little bit of interest from a company in Sweden who have been doing similar research with mice. So it's going along very well. The actual first study, just to give you some ideas of how many people took part, 48 took part, and 10 of which had no history of Raynaud's disease. And 50 minutes to acclimatise at 23, 24 degrees, and then 2 minutes of provocation at a sustained temperature, and then infrared images recorded 5 minutes beforehand, immediately post-provocation, and for 15 minutes afterwards. And a measurement called the distal dorsal difference, which is a parameter used by researchers before was taken, and I initially started measuring from the wrong place. So rather than, they had a machine which automatically would measure the whole of the back of the hand and give an average. It would automatically pinpoint and measure a place here. The software we have, you have to do every point by hand, you have to draw the areas by hand. And I'd been doing a point here and a point here. I'd misread, which then turned out that I'd created a new measurement area which was just as sensitive as the initial distal dorsal difference area, which means for anybody who's using our software, it can be done in half the time, and it's just as sensitive to the changes in people who have Raynaud's disease. And we started to build recovery profiles. Did this visually. Again, these images don't work here, so what I have got, just to show you, over a period of time, this is somebody who has non-Raynaud's hands. In a second, the hands will cut off. This is just before. This is when the hand had been in cold water. And so over a space of like 4 or 5 minutes, the hands are back to normal with good perfusion all the way through the fingers and the hands. The person who has Raynaud's, you can already see the hands are completely shut down. The areas which are very blue and dark blue are around about 8 degrees, 9 degrees, and a good 15, 16 degrees lower than the hand here. So cold water, even though you can see, and it's very dramatic, and you can see there's a problem here, Diagnostically, there's not a lot you can do with this other than say, yes, you have Raynaud. It's not really beneficial to the patient. Under warmth, these are my hands, glowing in the dark as usual. So again, very uniform colour all the way through. Before testing, round about now just after testing, and then they normalise very quickly. And again, this is somebody with Raynaud's disease here. So when it flashes in a second, it's not going to flash now, is it? Yes, it is. Okay, so this is when they came in. This is roughly where I warmed the hands, and then we were able to see that the hands shut down again, and then started to come back. And by the end of it, some fingers come back at different rates to the others. Areas of the hand have different rates of blood flow returning. So we were able to build some recovery profiles from this. Okay. And again, these are from the pilot study, and when I was looking at the patterns created, I noticed that there was a little bit of almost like a mirror image between warmth and cold. And this has been quite consistent. So this person here, who, during cold provocation, after the cold immediately drops, comes back, overshoots a little bit. This is called reactive hyperemia, where the blood comes back into the hands at a little bit too quick rate. This is where the pain and the burning comes from. And then they start to normalise again after 10-15 minutes. With the heating, this one here, this patient shot up just before the heating, started to go down, up, down, back up. And you get this wave sort of appearance, which is quite consistent with people who have Raynaud's disease. Whereas the normal, non-Raynaud's hands rather, pretty much uniform across. When you warm them, slightly above. On a cold day, slightly below. But again, there was very, very different patterns available there. So we knew there was something going on, and just information recordable from cold provoking and warm provoking. So yeah, this was presented, it was received very well at the World Physiological Conference. And importantly for my company, I was able to give them a final report of all these findings, all the material findings, and yes, we're able to then now. We've had prototypes made. I completed the transfer to PhD visa, and in the middle of all this, the Clinical Technology Diagnostic Research Unit was born, based in the chiropractic department and headed by Pete McCarthy. We've now got an extra KES project working in a different area completely, working on mattress comfort and use, which is very relative to people who have spinal problems. So that's a very nice chiropractic-related project. We also have a research assistant who is partly working with Raynaud, but is also working with cervical range of motion in elite rugby players. She worked with the Australian rugby team when they were over here recently, and other sports, American football, ice hockey, and all at national and international level. So we've got quite a good little research group going now. And the three of us who were working in that unit were all chiropractic graduates. They said they'd never had a graduate stay on before. And as soon as I did, people in the years below were interested, and I gave them talks, and we managed to keep one on last year, one on the year before, and we've got about 5 people applying to stay on this year. So it's nice. It started a trend in people who are leaving the course to try and do the research first, because you never come back. If you're working in practice, you would probably never go back and take 3-4 years out of practice to spend doing a full-time PhD. You would probably try and do research as part of a group out of your own clinic. So it's nice to see a few chiropractic graduates doing a research degree now, and hopefully that we'll all use it in the future. Very nice. So this is the CT Drew. This is my supervisor here, Pete McCarthy. And this is an internationally renowned anatomist who teaches on the course, Dr. Mark Langweiler. And he's a fantastic human being, he really is. So interesting. He's a Tai Chi master, amongst other things. Okay, so yeah, the first batch of gloves have been made, and they're currently being assessed by people with the condition. Everybody who took part in the project, whether they had Raynaud's or not, has been given a pair of these. The second gloves will be ready in January, so half the people who took part will be given a set of those and asked to change to see if there's any difference between the 2 pairs of gloves, whereas the other half will probably be given a placebo. That's still being negotiated at the moment. The second study had a lot of crossovers. So it was a case of all the people who came in and reacted to cold. I built profiles for them, exactly where the areas of destruction might be, based on the infrared findings. And they were crossed over. They were put into a warmth study. And I'd say, I've still got to analyse the data properly, but 90% of them, at roughly 90 to 95% of them, whether they were tested under cold or under warmth, the exact same fingers and locations were affected and I was able to get diagnostic information from. But each image takes a good few minutes to analyse, and I've got 2,000 to do, so it's going to take a while. I started working on the publications, and hopefully have 2 to 3 done before the end of it all. And the final study in March 2014, which will be a repeatability study, providing we have a March which is as cold as it was this year. Okay, so that's my project. I hope you got some ideas of what it is I'm doing. I'm just going to talk a little bit now about what I've learned. I mean, what all this means. Because as much as it's great to talk about my project, I'm as enthusiastic. It doesn't necessarily explain to you what I've learned here. Big thing I've learned is I spent 90% of my time doing paperwork and answering emails, and 10% on the actual research. And big thing I learned as well, there's never the same workload throughout a project. When it's human study time and I'm building and I'm getting the room ready and everyone's coming in and I've got something I can visibly quantify and I'm getting really excited and I'm seeing things under the camera and the people are sat there like this looking at me when I'm smiling at the computer and things. I love that. I love that time when it's busy and I've got things to do. Other times when I'm just answering emails and reading articles and quiet times, I get very depressed and bored. So I then decide to go and visit other universities to get out of my office. I've learned that Raynaud's disease is much more complex and poorly understood than I could have ever imagined. But there are more projects can come out of this. There's a big future for anybody else who wants to take up this type of research after me. And as such, I've managed to get a good 8 undergraduates over the last 3 years doing Raynaud projects as well. And the big thing I've learnt, people do not like having their hands put in cold water. A couple of people in particular, it's not just cold which causes the condition to manifest. It can be emotion, it can be trauma, it can be all these sort of things. And when the patient arrived, they were randomised well before. And when they came back, the people who'd been in the warm group, they knew they were going into the cold group. And before they even actually went in the cold water, their hands started to shut down. So there was an emotive reaction going on there as well, because they admitted they were nervous about being in the cold because they'd been involved in studies before where they'd been put in ice water. So this memory recall and panic was causing the Raynauds to happen before they'd actually been provoked. Another interesting phenomenon. As far as other skills I've picked up as a result of this project, as a result of the KESS project, I'm being allowed to do 6 hours teaching, 6 hours paid work a week on top of my contract. Kicked and screamed to say I want to start teaching as soon as I left, and they were very happy for me to teach chiropractic technique. And this year I started teaching the SPSS module to people on the chiropractic course as well. I've also completed a PG Cert in research, which was an extra nice little qualification to get. And what it's taught me mainly, and more than anything else, is project design, a research methodology. I always thought that a research project was you measure something and you analyse it and you write about it. I had no clue before starting this KESS project that there was such thing as qualitative research or anything. So the research project design aspect is a very, very big skill I've picked up, and now if I was ever going to be designing a project, I wouldn't just think about a quantitative study, what can I do here? I would actually look at every type of study and work out what's best for the particular problem we're trying to look at. I've learned how to use an infrared camera, which is not hard. You can train a monkey to do it. I think that's what they actually said to me when they were teaching me to do it, and they weren't far off the truth. And the big thing for me, which I'm getting more used to it now, writing in a scientific way. I used to write very creative stories, film scripts, poems, things like that when I was younger. So I had this very nice, over-elaborative, really descriptive way of writing, and they've had to physically beat it out of me over the last couple of years. But I'm getting more used to it now, anyway. Yep, presenting at conferences and seminars, something I would never have even considered doing before, and again, talking to people who are unfamiliar with the condition itself. Use of statistical analysis software, and other things I've picked up, other courses which I've attended at the university which were free for members of staff. And my favourite one recently, teaching students who do not speak much, or in some cases any English, so trying to give a lecture on musculoskeletal pain and explain my research to people who didn't really speak any English. It's quite difficult. And then of course, for big skill, using a sewing machine. With KES, we've done presentation days and national events. I was fortunate enough to win the University of South Wales KES Petra Culture 2012. Those of you who don't know what Petra Culture is, it's can you present your entire research project in 6 slides, and you've got 30 seconds for each slide. It's intense, it's not easy, and invariably, if something starts to go wrong, there's nothing you can do about it. You have to just try and get on with it, as Catherine knows. But it's a great experience, because if you can explain to somebody in 3 minutes what you're doing, it means that you understand it to a point, a very, very high level. So it's a great idea. I attended the graduate school 2012 in Tenby, wasn't it? I can't remember where it was, Penny. Pembrokeshire. And again, that was very intense over 2 days, but very enjoyable. Picked up a lot of new skills there. And in-house, we have a graduate, every year we have a graduate presentation day. I finished 3rd place 2012, 2nd place last year, so I'm going for 1st place next year, definitely. This is a picture of us at the postgraduate research day. And then this year, things just sort of exploded, went off on a complete different tangent, but I never would have expected. I was fortunate enough to be invited along on the first international doctoral school in Umeå in Sweden. And this suddenly is the first time I met students who were doing KES projects from other universities on a trip, meeting in the airport, catching free flights, being my ears destroyed by someone talking about broccoli all the time. And finding out what food dudes were. But it brought people together from Wales, Czech Republic, Sweden, Belgium, and it was supposed to be Portugal, but they weren't unable to attend. But we were also able to see how a different university operates their doctoral programs, which was fantastic. We were taken into industry while we were there. We had talks by different people from different areas, head of a doctoral program right away through to this Sami guy. I've completely forgot his name again. Can't remember his name. Indigenous people. Sort of specialises in indigenous people. Reindeer everywhere in Umeå. I thought I took that one out, sorry. And this was us, yeah, so I know you can't probably see from down there, but amongst other people, we had Penny, Stefan and Catherine with us over there as well. And this was all organised by KES Central, and Penny's department organised with the other universities, and was very successful.
Despite the fact that we didn't sleep, because it didn't go dark.
Yeah, that was a weird thing. We had 23 hours of daylight, and when it actually went dark, it was probably about as dark as this area here. So no, Stefan suffered, I suffered. I think Ollie went to sleep about 6 o'clock a.m. and woke up late every day. He was all right. Nice thing that was when we all left, we all said we'll keep in touch. And true to my word, I emailed some of the students from the other universities and said, I'd like to come and see your institute, shadow you for a little bit, and got responses from the student we met from Pardubice University and in Czech Republic, and I said, I'd like to come over and do some shadowing, but it evolved into them saying, would you mind disseminating some research and giving us some teaching as well. So I was over there all last week, and absolutely fantastic experience. And even more interesting, that the international doctoral school next year is at Pardubice University, so I was able to bring back some information for Penny. And I said I will pay for it. I'll pay to go myself next year if I have to. And this is the university at the main campus. I was given I met the people who were heading the doctoral programs in the healthcare department at the university. They gave me a tour. gave lectures to not just the students but some of the academic staff as well. I was invited to shadow an orthopaedic surgeon. It was the most bizarre experience. I went to the hospital, had a chat to him about surgeries he'd done. It turns out that he's a hand specialist who specialises in surgery of the hands, wrists, feet and toes, who just so happened to have trained in the hospital down 2 minutes from where 22 years. It was a very small world. And he gave me a bottle of very, very strong alcohol spirits and said, "Oh, come back on Friday and you can shadow me doing some reconstructions." So in the space of 2 minutes, me thinking I'm going to get a quick talk from this guy, I was being invited back to get scrubbed up and go into surgery again. So I was able to see things like hand reconstruction, shoulder reconstruction, things like that. And then the next person I met, a rheumatologist who just happened to be a specialist in Raynaud's disease. So what started off as a little email to 2 people I'd met saying, "Do you mind if I come and shadow?" suddenly had evolved into this project where I'm being paraded around as an international expert in musculoskeletal pain. There was advertisements everywhere, people from all over the university coming to being in a surgery scrubbed up, and then meeting a guy who's teaching me new techniques to evaluate people with Raynaud's disease. So just absolutely fantastic outcome to one email to somebody I met at a school in Sweden. The best part was on the last night, the ice hockey is their national sport, and we were invited to the ice hockey and didn't realise that we'd been given VIP tickets. I thought my friend who I'd met out there just happened to have these tickets. Didn't realise that the people we were sat with upstairs in the bar and lounge, who wouldn't let us pay for anything, saying, "Oh, the drinks are free, don't worry about it," which was great because it was my last night. It wasn't great on the train to Prague the next day. I had to hide in the toilet for an hour. Not 'cause I had a ticket, I wasn't feeling very well. So yeah, so yeah, it's not like I ever trained Wales. So this guy I was with all night, suddenly I kept being introduced to more and more people, like this is the second in command, this is the CEO, this is the club legend, this is a man of a match. I said, does this really happen all the time to people? Oh, no. And they took me down to the ice while they were playing. I said, "You can stand here for maybe 1 minute, but you'll have to go then because you'll distract the players." So I stood with the players. I was like, this is really bizarre, really bizarre. It turned out the person I'd been sat with all night was the owner of the club. And they'd been talking to him, and he said to me, he was talking to me for a while, and said to me, "You come work for me for 1 year in May." He says, "You quit, you come work for me for 1 year, I pay you good money." And offered me a job to work for 1 year, working with all his hockey players. So it was just really, really bizarre way to finish the week, to be offered a job there and then, which they still want me to go and do. And I told them that I can't unless we wait till August. This is the surgeon I was shadowing, Dr. Pilney. I said, "Can I take a photo for the scrapbook?" And he didn't look very happy, to say the least. So yeah, this is the student from Pardubitz VTech we met in Sweden. He was a main contact, he organised it all. I was taken to, amongst other wards, a paediatrics ward where I met the doll. This doll, one of the nurses works there, and every child who's about to have surgery, they spend time with the doll, they put videos on. You can open the doll and show them where different parts of the body, so if someone's having an appendix out, you can get the doll and get the kid to do the procedure themselves to show that it's perfectly safe. And it's just a really good way of getting the children happy before their surgeries. And they have so many different pictures of the doll set up in a book to show him after surgery. So that when the kid wakes up in surgery and they've got tube maybe or stitches, they don't wake up panic. They know exactly what they're going to wake up to. And it's a really, really nice, really good idea. I'm very impressed by the whole hospital. Every department has something which I thought was very unique, right down to, from physiotherapy, paediatrics, orthopedics. Absolutely fantastic. And yeah, I put this on here. As I was saying to Stefan before, if he puts a picture of me wearing this today, giving another talk, wearing the same jumper last week in part of it. Yeah, that was giving a talk there. This is Prague at night. Absolutely beautiful city. I was taken round by another of the students we met from the university when we were in Sweden, Susanna. She showed me Prague, which was quite amusing considering she didn't know where she was going and we did get lost. And this was the night at the ice hockey. I was given an ice hockey jersey as well. And this is a monument in Pardubit, which you see these monuments everywhere in the Czech Republic. They were erected to ward off the Black Plague, and every city has one of these built to protect them. And they're all fascinating. So yeah, just to finish up, all this has benefited me because I've now, as well as finishing the PhD next year, hopefully, I've got extra qualifications on top of a chiropractic degree. The KES programme offers a PSDA, Postgraduate Skills Development Award. So all these things that I've been doing, all the seminars you attend, all the times you present, they all count towards this award. And it's a nice award. It increases your CV and employability prospects immensely. If an employer sees you coming out with things like this, it's a fantastic thing to have. I've now got 3 employable skill areas, whereas when I graduated I had maybe 1. And yeah, starting to think about some of my postdocs relative to chiropractic. And I've definitely improved my chances of securing funding on any of these projects in the future, or improved my prospects of joining a research team somewhere. So short term, I intend to carry on doing this. I intend to go to more universities. I think the next stop I'm going to have to visit my own, because I just realised that I don't actually know what most of our departments do. And after seeing the departments here with Penny over the last couple of days, it'd be nice to have a comparison to see what our university actually does. And then, yeah, there is potential for a teaching and research position within the university I'm at now, although it would be better probably to move on for a few years. I've been at the same institute for 8 years now. And the main thing for any students, I'm trying to encourage them to do the same as I've been doing. I've got so much out of just a couple of visits and just a little bit extra. A few days out of the office doing something different. I'll come back in and I'll feel refreshed. I know I've got a much clearer picture of what to do. And anyone doing a KES project who has a travel budget, I really encourage them to do this, or any research degree with a travel budget, because you can't buy that experience. You can't quantify it by saying I've got 100 teaching hours. That's great, but to actually go out and see these things firsthand, it's generated new ideas. Even as simple as last night, it generated an idea seeing a piece of equipment up in the computer science. So I would recommend anyone do this. But eventually one day I'd like to return to the Welsh Institute of Chiropractic and teach, as well as having published quality research. A lot of the tutors there are due to retire in 4 years, so they're trying to tout me as a replacement in a number of different positions. So it'd be nice to go back there one day once I've done some postdoctorate work here. And yeah, encourage anybody who's thinking about a research degree to do it immediately after graduating, because I know that I would never have come back and done this. So yeah. And yeah, keep taking the bull by the horns. I only wrote this. I don't even like the phrase. It's just they've got a picture of me grabbing the bull's horns while I was in a restaurant in Pardubit. So I had to put that on there. Yeah, I've done so many talks and presentations. I haven't actually given thanks to anybody yet. So big thanks to Professor Pete McCarthy, Dr. Hoysh and Lee McCarthy, my supervision team, Leanne Crawley, the KES at the University of South Wales, and Paul Jarvis, who's taught me statistics to a point where I can now teach it myself. To my company supervisor at Tonus, to Penny and KES Central at Bangor University for allowing me to come here this week, as well as the trip to Umeå in the summer, and to Pardubit University, the healthcare team there, Vitek, Jan and Susanna, for making me so welcome last week. So thank you for listening. Sharks with human teeth, you can't really beat that, can you? And any questions? Thank you very much.